If you drop a surgeon into the human abdomen, they aren't looking at the colon as just like a simple digestive pipe.
No, definitely not.
Right. They're looking at it the way a structural engineer inspects a suspension bridge. They're actively hunting for the exact millimeter where the blood supply will fail, or, the architectural weak points under pressure.
Exactly. And the microscopic genetic flaws that just guarantee the whole system is going to eventually self-destruct.
Which requires a completely different perspective than traditional medicine.
It really does. I mean, a gastroenterologist might look at the colon and marvel at the physiology, right? The absorption of water, the delicate balance of the microbiome.
Production of butyrate for the colonocytes, all that stuff.
Yeah, all of that. But surgical thinking is entirely about anticipating structural collapse. It is a highly engineered, high-stakes organ. And the surgeon basically have to know exactly how to intercept a disaster.
And that is our mission for you today in this deep dive. We are taking a stack of medical blueprints from the Surgical Thinking Academy, and we're decoding them.
It's going to be fascinating.
We are going to map out the colon's danger zones. We'll examine how its structure fails, like right from the moment a baby is born to decades down the line. And we'll explore the extreme biological rewiring surgeons use to fix it.
Because to understand how the building collapses, you first have to understand how it was wired and plumbed in the first place.
Right, which actually starts before we are even born. The colon has this bizarre structural quirk where it does not grow as one continuous unit.
Yeah, that's one of the craziest things about it. It is assembled from two completely separate embryological origins.
Right, so the right side of your colon, meaning the cecum, the ascending colon, and the first two-thirds of the transverse colon that all grows out of the midgut.
But then the left side, so the rest of the transverse, the descending, the sigmoid, and the upper rectum, that grows out of the hindgut.
They develop on entirely different timelines and then essentially just, weld together in the middle of your abdomen.
And that weld line is a very specific spot. It's called the Cannonbone point, which is located right near the spleen at the splenic flexure.
Which is why, because of that dual origin, the physical architecture of the colon is just completely distinct from the rest of your digestive tract.
Oh, absolutely. If a surgeon is looking for it, there are three massive visual giveaways. You're basically looking for its structural signatures.
The TA mnemonic from the notes, right?
Exactly. So first, the colon has these three thick longitudinal muscle bands running down its length called the taeniae coli. And fascinatingly, if a surgeon is ever struggling to find the appendix, they just follow those muscle bands downward.
Because they all converge perfectly at the base of the appendix.
Right. It's like a built-in map. Second, the outside of the colon is studded with little teardrop-shaped fat tags called appendices epiploicae.
Such a wild anatomical feature.
It is. And third, the colon is segmented into these distinct pouches or saccules called haustra.
Plus, if you look inside the colon, it is completely smooth. Unlike the small intestine, which is, covered in millions of tiny finger-like villi to absorb nutrients.
Right. The colon has absolutely zero villi.
It is a completely different landscape. But sustaining that landscape requires a massive amount of energy. If we think of this organ as a building, it runs on two entirely separate power grids.
Which perfectly mirrors its embryological origins, going back to what we just talked about.
Right. The right side of the colon is powered by the superior mesenteric artery, or SMA, and the left side is powered by the inferior mesenteric artery, the IMA.
But the body knows better than to leave those two grids completely isolated from each other.
Right. It built in crosstown bypasses. You have this massive collateral vessel called the marginal artery of Drummond running parallel to the colon.
And a central connection called the arc of Riemann. They basically act as backup generators, linking the SMA and the IMA, just in case one goes down.
Which are brilliant anatomical safeguards, but they aren't perfect.
No, they aren't. And this is where surgical thinking really comes into play. A surgeon evaluates those arterial connections and immediately looks for the watershed areas.
The structural danger zones.
Right. These are the physical locations sitting at the absolute outer limits of those two power grids.
And in surgical anatomy, there are two notorious ones, Griffith's point and Sudek's point.
Yeah, so Griffith's point sits right at that embryological weld line we mentioned, the splenic flexure, where the SMA and IMA territories really struggle to overlap.
And Sudek's point is further down at the rectosigmoid junction, where the IMA meets the superior rectal artery. But what makes these specific coordinates so terrifying for a surgeon?
Well, they are ischemic hotspots. Imagine a city where the water pressure drops. The houses at the very end of the municipal pipeline are obviously the first to lose water.
Right. That makes sense.
So in the human body, if a patient goes into systemic shock, maybe from severe heart failure, or like massive blood loss, the body violently shunts blood away from the gut to protect the brain and the heart.
Because it's trying to save the most vital organ.
Exactly. And Griffiths and Sudeck's points are the furthest out on the pipeline. So they are the very first tissue to suffocate, turn black, and die from lack of oxygen.
Wow. So we've mapped the normal architecture and its natural weak points. But what happens when the blueprint itself is fundamentally flawed before the patient even takes their first breath?
Right, moving into pediatric pathology.
Yeah, specifically this devastating congenital condition called Hirschsprung's disease.
This is a profound example of a microscopic developmental failure causing just a massive structural disaster. Hirschsprung's is in the ganglionic megacolon, which is driven primarily by a mutation in the RET gene.
And it's significantly more common in males, right? And has a known association with Down syndrome.
It does. But the mechanism of the failure is what really makes it so dangerous.
Because the physical reality is that the baby is born missing the critical wiring in the gut wall, specifically two distinct nerve networks, the Auerbach and Meissner plexuses.
Right. And without those nerves, the colon loses all ability to perform peristalsis. It literally cannot perform the wave-like muscle contractions needed to move waste.
It's just paralyzed.
Actually, it goes beyond just not moving. Without those specific nerve plexuses, the muscle fibers cannot relax at all. So that section of the colon is permanently, rigidly clenched.
Oh, wow. So the clinical presentation for a neonate must be immediate and severe.
It is. They suffer from delayed meconium, meaning they fail to pass their first stool within the first 48 hours of life.
And their abdomen heavily distends and they begin bilious vomiting.
But the actual mechanics of the colon during this crisis are deeply counterintuitive. If you look at an imaging scan, you see this massive, swollen, dilated section of bowel.
But that giant swollen part isn't actually the sick part, is it?
No, it's a brilliant paradox of the disease. The hugely dilated portion is actually the normal, perfectly healthy bowel.
Right, because it is ballooning outward, because it is frantically working overdrive, just trying to force stool against a concrete wall.
Exactly.
Yeah.
The actual diseased, paralyzed, ganglionic section is the incredibly narrow, tightly clenched segment further down, which is typically in the rectosigmoid area.
The sick part is the narrow part. And this blockage creates an incredibly lethal downstream effect called HAEC, Hirschsprung-associated enterocolitis.
Yeah, this is the complication pediatric surgeons fear most. The stasis of stool in that dilated, healthy bowel leads to a catastrophic bacterial overgrowth.
And the pressure compromises the mucosal lining.
Right, so the bacteria cross into the bloodstream and the infant can rapidly spiral into life-threatening sepsis and shock.
So to fix this, a surgeon first has to definitively prove the wiring is missing. They run an anorectal manometry test to look for the loss of the RAR, the rectoanal inhibitory reflex.
Because in a normal system, when the rectum fills, the internal sphincter automatically relaxes to let things out. In Hirschsprung's, that reflex is completely absent.
But the ultimate gold standard for diagnosis is a physical biopsy, right?
It is. A pathologist examines a full-thickness or suction biopsy of the rectal tissue under a microscope.
Looking for zero ganglion cells.
Yes, zero ganglion cells and vastly elevated levels of acetylcholinesterase, which is an enzyme building up because the nerve signals literally have nowhere to go. If they see that, the diagnosis is locked.
And then the surgeon has to actually reconstruct the architecture. Historically, we saw procedures like the Swenson, the Duhamel retrorectal pull-through, and the Sauvé.
But today, the definitive maneuver is the TPT, the transanal endorectal pull-through.
Which is an incredible feat of biological engineering.
It really is. The surgeon operates transanally, carefully dissecting out the narrow, ganglionic, clenched section of the colon.
And then they take the healthy, dilated, fully innervated bowel from above, pull it all the way down through the pelvis, and stitch it directly to the anal canal.
You are physically removing the broken wiring and pulling the functional plumbing down to the exit point.
It's pure structural salvage.
Yeah.
And this mindset applies to other congenital issues too. Like for anorectal malformations, modern surgeons have moved past the old wing spread classifications.
Right. They now use the Krickenbeck classification to map the defect.
And they repair it using the PSRP technique, the posterior sagittal anorectoplasty.
Whether it's missing nerves or an imperforate anus, the surgical philosophy remains exactly the same. You identify the developmental flaw and surgically force the anatomy to function.
Okay, so we've explored what happens when the initial wiring is faulty. Let's look at what happens when the architecture is built perfectly, only for the body's own defense system to burn it to the ground decades later.
Oh, man.
Yeah, I am talking about ulcerative colitis, or UC.
Right. So we are shifting from congenital absence to acquired destruction. Ulcerative colitis is an inflammatory bowel disease where the immune system just relentlessly attacks the mucosal lining of the colon.
When you look at the pathology of UC, its defining hallmark is its uniformity. It doesn't skip around the bowel like Crohn's disease does.
No, the inflammation in UC is an unbroken, continuous sheet of destruction. It always begins at the rectum and marches backward, proximally up the colon.
The fact that the rectum is virtually always involved is a massive diagnostic anchor for surgeons.
And the depth of that destruction is equally important. UC only attacks the superficial mucosal layer.
Right, it strips away the surface lining, causing bloody diarrhea, but it does not chew transmurally through the entire thickness of the bowel wall.
But even so, the surface damage is catastrophic. Under a microscope, pathologists see crypt abscesses and a severe depletion of goblet cells.
And radiographically, the colon undergoes a terrifying transformation. Over years of chronic inflammation and scarring, the colon literally loses its structural integrity.
Those distinct pouches we talked about the Hofstra, they're completely burned away. The colon smooths out and becomes completely rigid.
It looks exactly like a featureless lead pipe on an X-ray.
Yeah, the lead pipe sign. And driving this damage is a very specific autoimmune profile. Patients with UC test negative for ACA antibodies, but they are positive for PANCA.
Which act like friendly fire missiles.
Exactly. The immune system gets confused and produces these antibodies that target the patient's own neutrophils, essentially tricking the body's white blood cells into attacking the colon surface.
Now, looking through the medical literature on this, there is one fact that completely stops me in my tracks. We know smoking is a systemic poison. It causes massive cardiovascular and pulmonary damage, but the data explicitly shows that for ulcerative colitis, smoking is actually protective.
It is one of the most astonishing paradoxes in human pathology. I mean, in Crohn's disease, smoking is a massive accelerant. It triggers flare-ups and worsens the disease.
But in ulcerative colitis,
In UC, the carbon monoxide and nicotine actually alter the mucosal immune response. They thicken the mucus layer and suppress the inflammation.
it is chemically protective,
Yeah.
which is just wild. Obviously, no physician is prescribing a pack of cigarettes to treat bowel disease, but purely from a biological standpoint, the fact that a known carcinogen shields the colon from this specific immune attack is mind-blowing.
It perfectly illustrates how radically different the microscopic battlegrounds of UC and Crohn's really are.
Right, and most patients manage this battleground medically, using, 5 ASA drugs like mesalazine for mild cases.
Or escalating to IV steroids and biologic anti-TNF therapies like infliximab for severe cases.
But a surgeon steps in when the medical shield fails. And the most terrifying reason a surgeon gets called is a complication known as toxic megacolon.
This is a state of imminent systemic collapse. The chronic inflammation becomes so severe that the paper-thin mucosal wall of the colon completely loses its muscle tone.
It just gives up.
Yeah, the colon balloons outward, dilating beyond 6 centimeters while the patient becomes profoundly septic and toxic.
And the triggers for toxic megacolon are incredibly common things. Administering an opiate, using standard antidiarrheal medications.
Or even just insufflating air during a routine colonoscopy can cause that weakened wall to suddenly expand and fail.
Because if that ballooned colon perforates, a lethal deluge of fecal matter and bacteria floods the abdominal cavity. The mortality rate just skyrockets.
Which is why surgeons operate based on strict indications. They step in for toxic megacolon, for an impending perforation, for a massive failed medical rescue with uncontrollable bleeding, or if the disease becomes totally refractory to all medications.
But there is one more indication, right? Dysplasia or cancer.
Yes.
If a patient has pancolitis, meaning their entire colon is inflamed, their risk of colorectal cancer increases by roughly 1% every single year after they've had the disease for 8 to 10 years.
Because that chronic, relentless cycle of ulceration and healing forces the mucosal cells to replicate at an unnatural speed.
Right, and eventually the DNA spell checkers just made a mistake, and cancer takes hold.
So when a surgeon does intervene for UC, the procedure is absolute. The gold standard is a total proctocolectomy with an IPAA, commonly known as a J-pouch.
Because the disease is strictly confined to the colon and the rectum, the only true biological cure is total extraction. The surgeon removes the entire colon and the entire rectum.
But to prevent the patient from needing a permanent external stoma bag, They perform an architectural marvel.
It really is.
They take the terminal end of the small intestine,
Hmm.
the ileum, fold it back on itself into the shape of a J, staple it together to create a brand new anatomical reservoir, and attach that directly to the anal sphincter.
You are literally building a replacement rectum out of small bowel tissue. It is brilliant, though it comes with its own risks. The most common complication post-surgery is cuchitis, right? Yeah.
An inflammation of that newly constructed reservoir, which usually responds to antibiotics like ciprofloxacin or metronidazole.
It is a massive physiological adjustment, but it fundamentally removes the diseased tissue and the cancer risk.
Exactly.
Which brings us to our final profound structural threat. We've moved from congenital wiring defects to inflammatory destruction. Now we enter the realm of absolute genetic destiny.
The time bombs.
Exactly. Why does a surgeon care so deeply about tiny microscopic bumps on the colon wall? Because some of them are the earliest structural fractures of a guaranteed collapse. We need to look at polyps and polyposis syndromes.
Identifying polyps requires intense risk stratification. The most common polyps are hyperplastic. They frequently pop up in the rectal sigmoid area, and structurally they are benign. They do not turn into cancer.
Right. The real threat comes from adenomatous polyps.
Yet when a surgeon reads a pathology report on an adenomatous polyp, they are looking for specific red flags that indicate a high potential for malignant transformation.
Like if the polyp is larger than 1 centimeter, or if the pathologist notes high-grade dysplasia, the alarm bells ring. But the most dangerous word on that report is villus.
Histology matters immensely. A tubular polyp is relatively smooth, but a villus polyp has microscopic, frond-like cauliflower projections.
Which drastically increases the surface area of the polyp.
Exactly, which means more cells are rapidly dividing, which mathematically increases the chance of a malignant mutation.
Surgeons are also deeply concerned with sessile morphology. Unlike a polyp on a stalk, a sessile polyp grows entirely flat against the colon wall.
Like the sessile serrated lesions, which are heavily linked to BRAF gene mutations. They are notoriously difficult to spot during a colonoscopy and incredibly hard to resect completely because they blend right into the mucosal wallpaper.
But these individual polyps are just like isolated sparks. The true genetic infernos are the hereditary polyposis syndromes.
Oh, without a doubt.
And the most terrifying of these is FAP, familial adenomatous polyposis. This is an autosomal dominant mutation in the APC gene on chromosome 5q21. The reality of FAP is staggering because it has 100% penetrance.
The APC gene is a tumor suppressor. When it is mutated in this specific way, the biological brakes are completely cut. If you inherit this mutation, you do not just have a high risk of the disease, you will absolutely get it.
Patients with FAP don't just develop a few polyps. Starting as early as age 10 or 15, their entire colon becomes carpeted with thousands upon thousands of adenomatous polyps.
It's devastating.
If a surgeon does not intervene, 100% of these patients will develop colorectal cancer, usually by age 35 to 40.
Because the cancer is a biological certainty, the surgical intervention is radical. The standard of care is a prophylactic latte, total proctocolectomy, entirely removing the colon and rectum, often when the patient is just in their late teens.
You are dismantling the organ before it has a chance to kill them. But the genetic error isn't just confined to the gut. FAP has 2 major variants.
Right.
Turcot syndrome pairs the polyps with deadly central nervous system tumors. And then there's Gardner syndrome, which proves how deeply this genetic flaw infiltrates the body's connective tissue.
Gardner syndrome is horrifying because the APC mutation triggers aggressive growth elsewhere. Patients develop osteomas, which are benign bone tumors, often on their jaw or skull. They develop epidermoid cysts, abnormal pigmentation in the retina of the eye.
And most critically, desmoid tumors.
Yes.
And this is the tragic irony of FAP. You perform this massive life-altering surgery in their teens to remove the colon and successfully dodge the colorectal cancer. But decades later, the second most common cause of death for these patients is those desmoid tumors.
Because desmoid tumors are massive, locally aggressive proliferations of fibrous connective tissue. They don't metastasize to other organs, but they grow relentlessly within the abdominal cavity,
wrapping around vital organs and blood vessels until they cause a fatal structural obstruction. The gut is gone, but the genetic flaw remains.
Exactly.
Contrasting FAP is the other major genetic giant, Lynch syndrome, historically known as HNPCC. This is driven by mutations in the MMR genes, the DNA mismatch repair genes.
Right, so if FAP is a total loss of the biological brakes, Lynch syndrome is a loss of the genetic spell checkers. The MMR genes are supposed to fix tiny errors during DNA replication.
But when they fail, you get a phenomenon called microsatellite instability high, or MSIH. Mutations rapidly compound.
Lynch is incredibly insidious because you don't get the giant warning sign of thousands of polyps. A Lynch patient might only have 1 or 2 flat polyps, usually hidden deep in the right side of the colon.
But those polyps fast-track into aggressive cancer in a fraction of a normal time.
Yeah, because the visual clues in the colon are so subtle. Diagnosing Lynch requires pure epidemiological detective work. Geneticists and surgeons use a strict family tree metric called the Amsterdam 2 criteria.
Often remembered as the 3-2-1-1 rule. You analyze the pedigree looking for this exact fingerprint.
Right, you need 3 relatives diagnosed with a Lynch-associated cancer. Those cases must span across 2 successive generations. At least one of those diagnoses must occur before the age of 50, and one of them must be a first-degree relative.
If that math checks out, the patient requires intense genetic sequencing.
And you cannot stop at the colon. Lynch-Eye's syndrome is confined to colorectal cancer, but Lynch to 2 explodes into extracolonic risks.
And the most severe extracolonic threat is endometrial cancer. The risk is so astronomically high that once a female patient with Lynch syndrome has completed her family planning, the surgical recommendation is a prophylactic hysterectomy and bilateral removal of the ovaries.
You basically have to remove the vulnerable tissue before the broken genetic spell checker turns it malignant.
It is the ultimate expression of surgical thinking. You identify the systemic flaw, map its inevitable destructive path, and surgically intercept it.
Perfectly said.
And just to demonstrate how diverse these structural flaws can be, surgical pathology recognizes a whole spectrum of rare variations.
Oh yeah, there's so many.
There's MEP-MUTYH-associated polyposis, which is unique because it is the only one driven by an autosomal recessive mutation. There's juvenile polyposis syndrome, driven by a SMAT4 gene mutation that causes massive bleeding hematomatous polyps in children.
Then there's Cowden syndrome, linked to the PTN gene, carrying huge risks for breast and thyroid cancer alongside gut polyps.
And then there's Cronkite-Canada syndrome, an incredibly rare, non-hereditary acquired condition where massive gastrointestinal polyposis is inexplicably paired with hair loss, nail dystrophy, and skin hyperpigmentation.
The sheer variety of ways the mucosal architecture can fail is staggering. Every single syndrome requires a totally different surgical strategy.
So what does this all mean for you listening? We started by viewing the colon not as a simple tube, but as a complex architectural blueprint.
Right.
We traced it from its dual-powered embryological collision at the cannon bone point. We analyzed the catastrophic pressure changes when its nerve wiring is missing in Hirschsprung's disease. We walked through the friendly fire disruption of ulcerative colitis and the radical biological rewiring of the J-pouch.
And finally, we confronted the microscopic genetic certainties of FAP and Lynch syndrome.
It proves that to truly understand the human body, you cannot just look at what an organ does today. You have to look at how it was built, where it is vulnerable, and how it will inevitably degrade tomorrow.
Exactly.
I want to leave you with a final thought to mull over. We constantly reduce the gut to its daily function digesting our lunch, but when you examine these surgical blueprints, the colon is really a living biological timeline.
It really is.
Its dual blood supply is a permanent historical record of our embryology. Its missing nerve plexuses perfectly capture the exact millisecond our neonatal development stalled, and its mucosal polyps hold the precise, unalterable genetic code of our future health. It is, without a doubt, a masterpiece of surgical thinking.
A phenomenal way to view our own anatomy.
Thank you so much for joining us on this deep dive. Output requirements for final script. 3 title ideas. 1. The Surgeon's Guide to the Colon. Anatomy, Inflammatory Battles, and Genetic Time Bombs. 2. Decoding Your Gut. Hirschsprung's, ulcerative colitis, and the polyps that matter. 3. Surgical Thinking. The Hidden Danger Zones and Genetic Blueprints of the Colon. Bullet summary of key source insights. Anatomical danger zones. The colon has dual blood supplies, SEMA, creating watershed areas at Griffiths and Sudex points that are highly vulnerable to ischemia. Hirschsprung's disease, caused by our ET gene mutation leading to missing nerve plexuses. It presents as neonatal ganglionic megacolon and is treated surgically with the transanal and rectal pull-through, TPT. Ulcerative colitis dynamics. UC uniquely features continuous mucosal inflammation starting at the rectum, PA and CA positive, with smoking surprisingly acting as a protective factor. Severe cases require a total proctocolectomy with a J-pouch. high-risk polyps. Adenomatous polyps with villus histology or a size greater than 1 centimeter carry the highest risk for malignant transformation. Genetic syndromes. FAP guarantees colorectal cancer by age 40 without prophylactic surgery, APC gene, while Lynch syndrome follows the 3211 family inheritance rule, MMR genes, and carries major risks for extraclonic cancers like endometrial cancer.